Unit 2. Patients with distress and anxiety. Stress can be defined as a response to any stimulus or condition that causes tension. Stressors are conditions that are perceived as a threat. Stressors can be divided into three categories: requirements, problems, and life events. When a person has difficulties in handling stressors, they may develop a condition of distress, which could eventually lead to the disruption of their normal functioning. Distress has been described by Reitner as the perception of a stressor as a personal threat, an inability to handle the stressor, loss of control, and a change in the person's emotional state. This is associated with feelings of discomfort, damage to health, and social dysfunction. The distress symptoms can manifest themselves in both physical and psychological symptoms, as well as headaches, stomach aches, and neck and back pain. A number of specific symptoms can be defined, such as constant worrying, irritability, fatigue, general malaise, emotional lability, nervousness, sleeping disorders, and impotence, as well as feelings of being overwhelmed, depression, and despondency. Coping is the way a person reacts both behaviorally and cognitively in relation to their emotional adaptation abilities. Failure to cope means that a person shows an insufficiency in stress management. The person no longer knows what to do about their problem and loses their grip on the situation. These are traits of demoralization. People give up, call in sick, and retreat from social interaction. In this way, a combination of psychological distress, demoralization, and impairment in social and/or occupational functioning occurs. Anxiety. Individuals with anxiety disorders experience excessive anxiety, fear, or worry, which is disproportionate to actual threat or danger and significantly interferes with normal daily functioning. Anxiety disorders can include a range of physical, for example, trembling, tense muscles, rapid breathing; cognitive, for example, worries, difficulty concentrating; emotional, for example, distress, negative affect, irritability; and behavioral, for example, difficulty sleeping, hyperarousal symptoms. Often, those with anxiety disorders develop maladaptive strategies to lessen anxiety, such as avoidance or substance use. Studies from Canada, the USA, Australia, Nigeria, and Europe suggest that 6% to 18% of adults experience an anxiety disorder every year. Moreover, rates of remission within 1 year are low, that is, from 33% to 42% across specific anxiety disorders. There are many types of anxiety disorders, including panic disorder, agoraphobia, social phobia, post-traumatic stress disorder, acute stress disorder, generalized anxiety disorder, obsessive-compulsive disorder, and specific phobia. These are diagnosed according to criteria outlined in the Diagnostic and Statistical Manual of Mental Disorders, or the International Classification of Diseases. Anxiety disorders often occur with each other, as well as with mood disorders and substance abuse or dependence. They tend to have an early onset and chronic course. Anxiety disorders also have a major economic impact. For instance, costs of direct treatment, unnecessary medical treatment, and work absences or lost productivity amount to more than $40 billion from United States per year in the United States. Description of the intervention. The most frequently used treatments for anxiety and depressive disorders include antidepressants and anti-anxiety medications. However, these can be unpopular with people due to side effects and the dislike of taking long-term medication. For example, from a systematic review of randomized controlled trials, 36.9% of people treated for anxiety with the second-generation antipsychotic drug quetiapine withdrew during the studies, and 33.9% of people with depression withdrew due to side effects from treatment for depression. Psychological therapies may also be used as treatments for anxiety and depression, and these are preferred over drugs. However, a lack of trained practitioners and funding mean that many people explore self-help options. There is interest from the community in the use of self-help and complementary therapies for anxiety and depression. A study in the US found that 20% of people with anxiety and 19% with depression visited a complementary or alternative therapy provider, with 2.8% and 5.4% choosing energy therapy. Patients with eating disorders. Eating disorders are characterized by disturbances of eating behaviors and a core psychopathology centered on food, eating, and body image concerns. The use of physiotherapy as an adjunctive treatment for patients' eating disorders within psychiatric healthcare and rehabilitation is based on the physiotherapist's expertise in both the body and the body in movement, two important issues integral to the pathology of ED. Eating disorders are considered one of the most challenging psychiatric conditions. The spectrum of ED ranges from mild to severe. The severe form of this behavior results in the clinically recognized diagnosis of anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia nervosa is characterized by a refusal to maintain a minimally normal body weight and a distorted perception of one's body, weight, size, shape, namely a negative experience of their appearance as too fat and an intense fear of gaining weight, even when severely underweight. Bulimia nervosa is characterized by repeated episodes of binge eating, followed by inappropriate compensatory behaviors, such as self-induced vomiting, misuse of laxatives or other medications, fasting or excessive exercise. Binge eating disorder is characterized by recurrent episodes of binge eating and a sense of lack of control over eating, and is associated with psychiatric comorbidity and significant medical and psychosocial impairments. Eating disorders are associated with notable quality of life impairment and impact on home, work, personal and social life, and economic cost. Eating disorders also frequently co-occur with other mental health disorders, particularly anxiety disorders and depression. The peak age of onset of anorexia nervosa is in early to mid-adolescence, but may occur at any age, including in childhood, where the gender balance is more even. The reasons for the greater number of boys presenting in childhood years are unclear. In bulimia nervosa and binge eating disorder, onset is more commonly in later adolescence and young adulthood, and binge eating disorder is more likely a midlife disorder with a much more even gender frequency. It is important to be aware that all eating disorders can and do arise at any age and in both females and males. In addition, eating disorders often go undiagnosed and untreated. Thus, it is common for adults to present for treatment many years after onset, even into late middle age. However, most people make a sustained recovery with treatment. This includes people with anorexia nervosa, where up to 40% of adults and a higher percent of adolescents will make a good 5-year recovery, a further 40% a partial recovery, and those with persistent illness may yet benefit from supportive therapies. For those with bulimia nervosa, at least 50% fully recover, and the outcomes with treatment are also good, if not better, for binge eating disorder.